Hello, everyone. Welcome to another module of DRTB management. The next module is on TB preventative therapy for rifampicin-resistant TB household contacts. I'm Dr. Abel Greg Modiba. So I'll be taking you through this module. So in terms of this module, what will be in terms of the criteria of inclusion criteria, or those that are going to be considered, are all household contacts of rifampicin resistant TB patients. Number two, it's those with multi-drug resistant TB and extensive drug resistant TB, your commonly known as your XDR TB. And then the third category, irrespective of HIV status and age, but with no TB disease or symptoms and signs of TB. So those who have been excluded of TB through the symptoms or not being on having TB disease. So these are the inclusion criteria. Whereas the exclusion criteria for the TPT in the TB treatment, the exclusion criteria, those are excluded, those with confirmed DSTB or RRTB disease. So you can consider TPT on these patients because they've already confirmed disease. So you can be considering them on the TPT. The other group that you can consider for TPT are those with the presence of symptoms and signs of TB. And then those ones that can never be considered are those with active liver disease, because the drugs that you are using for TPT get metabolized on the liver. So if your patient has got an existing liver problems, it's going to cause problems with the absorption of the drug. Now, also the other category is the presence of symptoms and signs of peripheral neuropathy. So these are the patients with numbness, tingling. If the sensory findings, it's your numbness, tingling sensation that the patient normally has. So normally the drug that we use for TPT also cause the same problem. So if a patient has got signs of this, you wouldn't want to give this patient TPT because of an existing peripheral neuropathy. The other category is the patient with a history of adverse reaction to any drugs used for TPT. So if your patient was previously given your TPT, so you wouldn't want to give it again if you had a reaction to it and you tried to re-challenge it again. The other one is excessive use of alcohol. And we are going to take a few minutes to tackle in terms of what do we mean when you say excessive use of alcohol. So it divided into two groups. For men, we mean if they are taking more than 4 standard drinks on any day or for 14 per week. That's a 4 standard drink on any day for a patient, especially male. For women, it's more than 3 standard drinks on any day or 14 per week. I'm going to explain on my next slide what do I mean when I say standard drinks or for a patient. But this is what we mean when we say excessive use of alcohol. If they have 4 standard drinks per day. When I mean standard drinks, we're talking about alcohol usage here. Now, the equivalence, how to measure the standard drink with alcoholic, the equivalent of standard drink is calculated based on the percentage of alcohol in the drink. So what do I mean? If a patient is using beer or wine coolers, so normally your beer and your wine coolers are typically having 5% of alcohol. So your standard drink is 360 mils. I think it could be also a can of a drink. So if a patient is a male is taking 4 of this 360 mils a day, that patient is considered to have having an increased alcohol usage. So that's how you measure it on a patient. whereas those who are using malt liquor, they approximately this consists of 7% of alcohol. Its standard drink, it's 240 to 270. It could be a glass of it, of the patient that is taking it. And the cider consists of 6% of alcohol. Its standard drink is 300 mils, which could also be almost a glass or a cup. Whereas a wine, which a table wine has got 12% of alcohol, table wine, which its standard drink on this, it's 150 mils of wine. It could be a bit of a quarter or half of a glass. And then fortified wines, such as your sherry or port, that are a bit stronger. Its standard drink is 90 to 120 mils. Those are tots, 3 or 4 tots on the patient. They are considered a standard drink per day. So the spirits and liquors the patient uses, the spirits typically contain 40% of alcohol. That's a high alcohol that is contained inside that liquor drink. So while liquor typically contains less alcohol, the standard drink of a whiskey, a gin, vodka, and brandy is 45 mils. That's a standard 45 mils. So that's a two tots, yeah. While a standard drink of a liquor of like a cordial or an aperitif, it's 60 to 90 mils. So a shot is typically filled to 45 mils. So these ones, it's 2 shots, which is the equivalent of a standard drink. So if they are taking 2 or more shots a day, they could be considered as using of alcohol that is excessive. So this is how you measure alcohol drinks. Now, how do we manage contact of rifampicin-resistant TB patients? Firstly, you have to do what you call symptom screening of all patients. They need to be screened for symptoms. All adults and adolescents who are household contacts of RRTB, irrespective of their HIV, should be screened for TB symptoms and signs, and if found to be asymptomatic, assessed for eligibility for TPT. So when you have an index, patients who is diagnosed with RRTB, you need to go to the people he stays with and screen them, people he works with, their friends, neighbors, screen them for RRTB or for TB. Now, the preventative treatment should be individualized, and we're going to be talking about that individualized treatment. After a careful assessment of the intensity of the exposure and the certainty of the source case. So it will give you an indication in terms of what kind of treatment you are going to be taking based on the source case in terms of its resistant pattern of the patient. So that reliable information will give you in terms of what kind of treatment or TPT the patient is going to be taking. Now, we categorize those patients that are eligible for TPT as a high risk. So those are the ones that needs to be offered the TPT, the high risk patients. So we classify them as high risk. And who are those high risk patients? Are the children under 5 children. The other one is people living with HIV, people living with HIV as contacts, and individuals receiving immunosuppressive therapy, whether it's a chemotherapy or radiation therapy that is very immunosuppressive. So those patients, especially the cancer patients, they are also categorized as high risk. So these are the individuals that are eligible in terms of for TPT after being screened, and if they are contacts after being screened negative for TB, then you have to consider giving them TPT. So the drug selected according to the drug substitute profile of the source case. So this is what I mentioned, that you look at the susceptibility of the patients or the source case in terms of what treatment was it taken, which ones on those treatment or which drug was susceptible. and then which one was resistant, and that will give you a guidance. But we'll talk about it on our next slide. Now, as I highlighted, the management options, there are two main management options for person exposed to RRTB infection. So those ones are the ones who have no signs and symptoms of TB, right? So option number one, for contact exposed to patients with fluoroquinolones or fluoroquinolones that is susceptible. So obviously, you remember I earlier said you look at the source case in terms of their pattern, the susceptibility pattern. So the one that we looked at, it's a fluoroquinolones susceptibility. So if the patients, fluoroquinolones are susceptible, so those patients, it means we might give them a regimen that is having fluoroquinolones like levofloxacin. So it can be given alone as a TPT for that patient, or be given in combination with ethambutol or high dose INH. So if you have a patient with fluoroquinolones susceptible, the TPT for that patient could be levofloxacin given alone, or given in combination with ethambutol or with high dose INH on that patient. That's the option one of that patient. Now, there are two main options for persons exposed to RRTB who have no signs and symptoms. So the other option, you can give single drug INH or normal or high dose for 6 months for exposure to rifampicin monoresistance, where susceptibility to INH is confirmed. So this is the most common one. If your patient is having your INH susceptibility, so you can give your normal dose of INH for 6 months on that patient. But if your patient has got the rifampicin, has got your INH resident with or with a MDR-TB with INH mutation only, this could be considered for contact exposed to fluoroquinolone resistance. So this patient also, you could also give high dose INH. So these are the patients where this is the normal regimen that we normally give to our contacts, commonly regimen or option that we normally give to patients. The high dose INH for patients. So the other option is the levo, as I highlighted, especially if fluoroquinolones are susceptible. So you can give levo for 6 months for those patients with KG mutation documented, where quinolones are susceptible. So these are the three options: your single drug regimen with a normal INH, your higher dose INH, levofloxacin, or you can have levofloxacin with high dose INH together. Now, treatment option 2 is when the index patient has got fluoroquinolone resistant. So you remember treatment option 1 is when you have a fluoroquinolone susceptible. So treatment option 2 is when you have a fluoroquinolone that is resistant. So in this case, we are going to give high dose INH, okay? Single drug high dose INH, 10 to 15 milligrams in adults, 15 to 20 milligrams in children for a duration of 6 months. So these are the treatment you give for the contacts after being screened negative for TB symptoms. So in terms of your monitoring for this patient, patients should be educated and counseled about the risk of developing TB disease. So TB signs and symptoms and the importance of reporting to health facility for any assessment for TB once the symptoms have developed. So the patient have to be regularly come to the facility where they're going to be screened and check if there's any development of TB, because if the TB can develop where their own mono drug treatment, they could increase them to resistance. So you need to make sure that the patient is screened on a regular basis, and then if they develop anything, they must come back for assessment at the facility. So what do we do? Contact should be screened for TB every 3 months for the first 12 months, and every 6 months up to 24 months after initial exposure. Whereas children may require monthly follow-up for the first 6 to 9 months, and then 3 monthly until 24 months. So these are the follow-up in terms of making sure that those patients don't develop TB while they are staying with, or they are staying with a source patient who has a TB. Now, in summary of what I was talking about, with the type 1 treatment or management of contacts, if the source case has got fluoroquinolones acceptable, the medicine, you could give levofloxacin, both for adults and children, or you could give high dose INH, or you can give the combination of the 2 or the 3 of them together. So both the adult and the children can be offered, and the dose is 15 milligrams per kilo in adult and 15 to 20 milligrams per kilo in children. It's taken daily for a duration of 6 months for all of them, all of this treatment. So what is also important is to give pyridoxine on these patients with a dose of 25 to 50 milligrams per day. Okay. Now, still on type 1 with fluoroquinolone acceptable. If they have a KG mutation, you can put them on levofloxacin mono treatment. And then they also, if they have a INH mutation, you could give them a combination of levo and high dose INH. So the source case plays a major role in terms of what their treatment outcome or the resistant pattern of the patient with their mutation. It guides you in terms of your TPT. Now, whereas mono-resistance to rifampicin, INH normal dose, especially if there's no any resistance to INH. So you can give a normal dose of INH, which in adults 46 milligrams, in children 10 milligrams per kilo for a duration of 6 months. Whereas the type 2 management, where there's fluoroquinolone is resistant, you could give high dose of INH in adults and then also in children, which a dose of 10 to 15 milligrams per kilo. In children, 15 to 20 milligrams per kilo for a duration of 6 months daily, once daily. And the other option, which normally we could say is a very expensive option, it's your delanamide, because delanamide is not easily available like your INH. Is not easily available. Mostly it's controlled in the center of excellence, so it's not easily accessible. So that, hence, it could be another option in those facilities that are easily accessible as a TPT for a patient with fluoroquinolone resistance. In those instances, only adults could be offered that, obviously considering their weight. For in that case, then you calculate it. It's different because it's given twice and daily. All right, for a duration of 6 months. Now, patients are offered a treatment for latent TB infection. So these are the patients who are having contacts and then they don't have any symptoms. So we categorize them as latent TB infection. They can be categorized as new or previously treated with TB. So you have to give them an outcome. The only treatment outcome possibilities are completed, lost to follow, stopped, or died, as described in the slides to follow. So you have to give a patient an outcome after the TPT. You have to give whether it was completed or patient lost to fall, or a patient stopped it, or patient passed away while on the TPT. So treatment outcome has to be given. Now, in terms of the definition of category, when you say a patient is new, say a contact who has never had treatment for TB infection or IPT or never received it before or took any treatment for less than 4 weeks. And then the second category is previously treated. This one is a contact who has taken treatment for TB infection before. It's either for a duration of 4 weeks or more. And then either completed or stopped it, whatever reason. So this way, just previously treated. So you categorize them as previously treated when they are about to start another TPT. The other treatment outcome is loss to follow. So these are the contact whose treatment was interrupted for 3 consecutive months or more during the treatment period. So you categorize them as loss to follow. And then treatment stopped, a contact whose treatment was stopped during the treatment period and as a result of serious adverse event or development of TPT. So if a patient was on TPT and then he developed TB on TPT, your outcome, it will be treatment stopped, and then the patient could start on TB disease as another outcome will be given on that patient. Now, the other one is died. So this one is a contact who died for any reason during the course of TB treatment. So if a patient died, the outcome is you died. Thank you very much.